Hola, bienvenidos a su podcast Women's Hub con el Dr. Abner Santos, a un nuevo episodio donde hablaremos de un tema muy importante. Pero hoy tengo un invitado muy especial conmigo. Tendremos un episodio en inglés, por cierto. Pondremos subtítulos para todos, para que todos puedan entenderlo. Pero tengo conmigo a un profesor muy especial que viene desde Estados Unidos, de New Jersey, y él es el Dr. Suffidini Mama, y él es alguien que tiene más de 30 años de experiencia en la práctica clínica de casos muy complejos. Él es ginecólogo graduado en Estados Unidos en la Universidad de Yale, pero también es uroginecólogo y experto cirujano pélvico reconstructivo. Se ha especializado también en el área de pediatría y adolescentes en casos complejos de anomalías en este tipo de pacientes. Así que tenemos con nosotros una gran oportunidad de llevar una información que de una forma muy difícil podríamos llevarla. Así que estoy muy contento con esto. Y vamos a empezar. Dr. Mama, welcome to this podcast. Thank you for accepting my invitation to talk about some topics which you are expert in the world. So I want to share your knowledge. I want to take your brain out and share it to the world. That's what we are going to do right now.
Thank you.
So thank you for being here with me. And I want to hear a little bit of your background, your history that you want to share with us.
I work as a teacher and a professor at Cooper Medical. Is a Cooper Medical School in New Jersey, CMSRU, Cooper Medical School or Rowan University. I've been there for about 20 years. And before that, I was with the University of Pennsylvania for about 10 years. And my background is urogynecology, but also minimally invasive gynecology and robotics, as well as pediatric and adolescent gynecology. So I have a couple of different areas of subspecialization within gynecology.
Yeah, I think I forgot to mention that because actually in Guatemala, we don't have robots yet. Hopefully in the near future, we're going to have it. But laparoscopy, we do have a lot of specialists in laparoscopy, but actually laparoscopy is a very complex field also that you need to increase your abilities, your skills to become really skilled surgeon in that. So I believe you have seen a lot of complex cases. That's one of the main reasons I want to have you here to share with us. Because when we talk about complex cases, what can we say about a complex case? How do we define what is complex and what is simple when we treat patients?
Well, it depends on the age of the person and the kind of disease and or whether they've had prior surgery. So take, for example, a young woman who comes with pain, and you ask questions and you find that she has pain every single menstrual cycle. And you ask more questions and she has pain before her period, before the menstrual cycle, and it comes every month. And you're thinking, she's a teenager, she might have endometriosis. The only way to prove that imaging is not enough, you sometimes have to operate. You start with basic medication, hormonal treatment. If that doesn't work, then you need to do laparoscopy. But when you do laparoscopy, then you really have to remove all the endometriosis. And if you don't, then the patient continues to have cyclical pelvic pain, which can be very severe. So that's an example of use of laparoscopy for a very specific disease, but it's very important.
And it's really complex because we are hearing a lot more about endometriosis than in the past. And one of the things that I get most interested with endometriosis is that actually we know very little about endometriosis, but we have found endometriosis in places that at some point looked that this is impossible. I was telling you yesterday about a case where I didn't know that a mass in the bladder was actually endometriosis. And I have heard, because I haven't seen myself actually, but I have heard about cases of endometriosis in the diaphragm, in the kidneys, and even in the lungs. That's incredible. How can we define what is endometriosis?
So endometriosis, in essence, is a chronic inflammatory disease. When I use the word chronic, think of diabetes. It doesn't go away. Endometriosis doesn't go away. And it's a chronic disease and it's inflammatory. That means it causes swelling. So patients with endometriosis start usually with pain before their period and with their period, their menses. Eventually, as it gets worse, they have pain all the time, all month long. And it is essentially tissue that is supposed to be within the uterus as part of menses with the blood. Those cells are now outside the uterus and they're in the pelvis and they adhere, they stick to the walls. Then the body is responding to this with inflammation. Then eventually nerves grow into it. Blood vessels grow into it. Every month when a woman is having her menstrual cycle, she's also bleeding inside. And it is not easy, in fact, usually very difficult to see on ultrasound or MRI. So a young person can say, I'm having a lot of pain, and you do the studies and you find nothing, but they have the disease.
That's the difficult part. It's like endometriosis create its own system, ecosystem.
Yes.
And we have a really hard time to diagnose. I think that's the main problem that we have, or tools for diagnosis.
Yes.
How can we say to the one who's listening to us, when to think or suspect that you are, or as a girl is having endometriosis? What are the main signs that may do to allow you to think, okay, this could be endometriosis? How do I detect them?
Probably the most important thing is to not assume that a woman's pain is in her head. If you have a young woman who says my menses is very painful, enough that she's missing school or taking medicine or cannot do normal activities, then the first thought is why? Why is she unable to do it? So investigate. First thought is do an ultrasound. See a doctor, of course, early. You don't need an exam, you need an ultrasound. Ultrasound will tell you that the anatomy in the pelvis is normal. There's no tumor, there's nothing serious. Endometriosis also, as you know, can be inside the ovary. So the ultrasound is very useful to make sure the ovaries are normal. But let's say the ultrasound is normal and the woman is in pain and she's 14 years old, a young teenager. Well, you have to think, all right, she's having pain every month and pain before her period. That's a sign of endometriosis. Then the solution is to put her on hormone therapy and see if 4 to 6 months of treatment would help her. If it does not help her, then she needs specialized help laparoscopically to look inside the body and either diagnose or at the same time treat the problem. So it's about early detection of a problem by paying attention to the patient's symptoms.
Not ignoring what they are saying, not
Correct.
ignoring the pain, not believing.
Correct.
I have heard a lot of patients when they come to my clinic and they say, I have pain, but it's the normal pain. And I say, what's that? What's the definition of a normal pain with menses? Yes. I think that there's not quite that definition of a normal pain in menses.
So across the world, 90% of women will say they have pain with their menses, but I use the word normalization of the abnormal. In other words, you are taking something that is not correct and you're making it less important. So much more important to say, you're having pain. Let's find out why. Not just say, well, you're a woman, you have your menses, this is how it is.
You have to deal with this.
Yeah, it's not logical because you often miss many things, not just endometriosis, but even painful periods, just painful. There is no reason for that person to miss school, to miss work. If they're older, you can do something with medication. So there's no real reason to ignore the symptoms. The biggest, complaint that I've heard my whole life from patients is nobody listened.
Yeah,
I hear that word all the time.
Like loneliness for them.
Just nobody listened. Thank goodness somebody is listening. So for us in medicine, particularly, very important to allow the patient to tell us what is really bothering them and pay attention to it. Maybe they have a clue for you.
Yeah, and there's one thing you said, and is the difficult of imaging diagnosis. Because, for example, we have ultrasound tools, but you can use ultrasound only if you are really trained to look for endometriosis. Well, if you look at endometrioma, this 1, 2 centimeters, 3 centimeters is easy to see to any gynecologist. But if you are having just small spots of endometriosis dispersed in the abdominal cavity, it's really difficult.
Yes.
Then we have MRI, that can help us. But actually, you need also training. I have a lot of patients where I send them to MRI, and the MRI comes normal.
Correct.
And they complain about pain. And they say, but how can it be normal? Nowadays, what I say is that the result is normal. Doesn't mean that you don't have endometriosis. But what do we need to get a better diagnosis, at least with the imaging process, before to get into the laparoscopy?
So there are a few centers where people say that they can on MRI detect endometriosis. The problem with that is you need to be standardized. In other words, if only two places say they can see it and everybody else cannot, it's not helpful. So ultrasound and MRI can spot big amount of endometriosis. So think of a lot of endometriosis, say, deep in the pelvis on the uterosacral ligament. You might see nodularity and you go, MRI says there's endometriosis. But that's very obvious. For most patients, the ultrasound and MRI will show nothing.
Okay.
And so the answer isn't the imaging, is just a tool to rule out endometriosis inside the ovary. So you don't have endometrioma, you say, great, wonderful, the ovaries themselves are normal, there's no tumor inside with endometriosis inside the ovary. But after that, it is a clinical diagnosis. And usually for a number of women, young women, being on hormonal treatment, birth control pills, over 4 to 6 months can decrease the pain. Now, one other thing that I've seen for my whole lifetime is parents don't like the idea of birth control pills because they are thinking about this in terms of sex. But this is a mistake. This has nothing to do with sex. This is treatment. It's like having blood pressure and you give a medicine. Yeah. So the way to think of it is you're giving a young woman medication, and if after 4 to 6 months she's in less pain, you have solved the problem. You don't have to operate. Yeah. But if after 4 to 6 months the pain has not decreased or has even increased, then you're forced to do laparoscopy to find out what is inside. Once you're inside the body on laparoscopy and you see endometriosis, then the solution, of course, is to remove everything, to excise everything, to decrease the amount of disease, and then put the patient back on hormonal therapy. So it is an invisible disease, which is why it's so hard for women.
Yeah, invisible disease and diminished disease also, because we know so little of it. And when you perform a laparoscopy, finally you get into the necessity of going to laparoscopy. There's recently an evolution on this, and deep endometriosis is making these cases really complex every time. Yes. So it requires a very skilled surgeon at first with proper training for going to this deep endometriosis. And what's your best advice in case someone is listening to us and they are gynecologic surgeons, for example?
Yes.
What's the need for being able to perform a good laparoscopic surgery actually to make the most excision possible of all the endometriosis?
So 2 things come to mind. Number 1, you can go in and do a diagnostic laparoscopy and you see endometriosis. And let's say you see endometriosis on the rectosigmoid, or you see it on the peritoneum on top of the ureter, and you're not feeling comfortable with removing it. That is okay. You can finish the surgery and refer the patient to somebody who has the skill to do it. Or preferably, if you want to really do this, do it with somebody who has expertise and learn. Or refer to somebody who has expertise. There is very good evidence that just burning the endometriosis on the surface, fulguration is not enough. Yeah. There's very clear evidence. You have to excise all of it. So it's a matter of doing it safely, and there are always people who have the skill. And my answer is very simple. You refer or you work together, one or the other.
Yeah, work as a team.
Yeah, exactly.
And then, for example, it's difficult, any case we chose is difficult for parents and obviously for the girl in this case, because either way you go for long-time medications like suppression medication with contraceptives,
right,
or you go to surgery. But right now, like, the goal is not that many surgeries, because I've heard about girls that already have like 10, 11, 15 surgeries because of endometriosis. And that's the thing that we need to avoid.
So endometriosis, again, being a chronic disease, the solution is the surgery is for diagnosis and maximum treatment. But once maximum treatment is finished, you have to do hormonal therapy. You cannot just say the surgery is done. Otherwise, within 2 to 5 years, you're back with more surgery, or even less. Yeah. So hormonal treatment, even sometimes with hormonal treatment, maximum hormonal treatment using birth control pills plus extra progesterone, still patients will progress in disease. But the vast majority, you can try to avoid multiple surgeries.
Yeah. This is really a hard topic to explain to patients, because if most of them think, okay, I'm going to surgery because I won't take medications, or I don't like medications, or I will not take medications. But at the end, you have the surgery, but you have to keep medication.
Yes.
So this is a hard topic for parents and for the small girls. And how to explain it, the consequences of not doing nothing for endometriosis. What are the main consequences of not doing nothing for endometriosis?
Because it's a chronic disease, it will continue. It will cause more scarring. So I've had situations where there's been untreated disease in women who are now in their late 20s, early 30s. Now you have disease that is spread. The entire pelvis is essentially frozen.
Wow.
When we use the word frozen, the uterus, the rectosigmoid, the ovaries, the side wall, everything is stuck. I mean, really stuck. And these are very difficult, complex surgeries with a high risk of injury. So doing nothing is the same as allowing the disease to progress. So another way to look at this is, if I said to somebody, I'm so sorry, but you have very high blood pressure. If you don't take this medicine, you will have a stroke. People will take the medicine. Nobody wants to have a stroke and die. It's that sort of thinking that you have to do something after the surgery. You cannot just say the surgery, I feel better now. It's only for a short while. You must do more.
I think that probably we have looked at endometriosis until recent days like a variation of normality, but it is not normal. It is a disease, actually, and we have to look at it. If we look at it as a disease, like you mentioned, if you have high blood pressure, if you have diabetes, you will not question that you need to take medication for a long time. But if you look at it like a normal variation, or as something that is going on and just you are bad luck and you will probably this will resolve, well, there's the point where the expectation is, okay, if this is a normal variation, okay, I can live with this, nothing will happen. But if you look at this as a disease, you will understand that you will need treatment and probably for a long time.
Also, keep in mind that you can increase your risk with all of this scarring and bleeding internally and everything being frozen. It would be harder to get pregnant.
Well, yeah,
because
you're
going to have fertility issues. The fallopian tubes that are very delicate could be damaged, but may not have to be damaged if you had done the right thing early in life, in the teenage years.
Yeah. And talking about not only fertility, because that probably is for another podcast, but for example, when does endometriosis ends? Does this stop at some point, or at least does it get better at some point of life in a woman's life?
So when women have endometriosis, let's say you've actually proven it and you've done a laparoscopy, when they go to menopause at 52 and a half, 53, there is no more estrogen from the ovaries. That's the driver for endometriosis, right? That is what fuels the endometriosis. So then you can say endometriosis will end. The only other way is if you do surgery and remove both ovaries, but that puts a woman into early menopause. So this is a very long disease, starting when you are having your menses for the first time all the way to menopause. There's many decades for it to get worse.
Yeah, because it starts like in adolescence.
It starts when you have your menses, the first one. May not know it, but within a year, if you're having increasing pain before your periods, pain with bowel movements, frequency of urination, you get nausea, vomiting, you should begin to think, why? Why always with my menstrual cycle do I have all these problems? General good rule for parents, if your daughter has symptoms around the menses that are severe, whatever they may be, find a doctor, see a gynecologist, see a specialist, find out why.
Yeah, and I have heard in one of your talks that you mentioned that many of the causes for endometriosis could be an genitourinary anomaly.
Yes.
So that it starts probably from birth and can develop until early years in the pediatric age or even in adolescence. And many diagnoses are made until really late time, 18, 20 years.
Yes.
Can you talk about a little bit more about what anomalies probably produce and how they produce endometriosis?
So just to back up a little bit, for a woman has a uterus, the womb. The baby will be in there. Coming from the uterus are the fallopian tubes. They will capture the egg from the ovary. The uterus, end of the uterus is the cervix. That's where the baby will pass through in the vagina and come out, right?
Yeah.
You know the basics. Now, let's say you are born, and you're born with two uteruses, but you don't know.
Yeah.
And one is blocked, and one is not.
Oh.
Now you turn 12 years old. You have your first period. Then you have your second menses a month later, then a third menses, and then you notice your pain is increasing. Somebody will say, well, you're having your period every month, you should be fine.
So everything's
Well,
okay.
what you don't know is the other uterus is blocked, and that blood is filling that uterus and going backwards into the body.
It's like getting trapped and getting to retrograde.
And therefore, if it's retrograde, it's going to cause endometriosis. So anything that blocks the flow of blood for a woman at any age is going to go backwards into the body, and that's going to cause endometriosis. So for young women, when they first start developing, first breasts develop, pubic hair, but once that develops, within 2 years, if there is no menses and the young girl has developed every other way, you should see a pediatrician. You should see a gynecologist. The question is, why don't you have your menses? So either you're blocked and nothing can come out, or you have two uteruses and one is blocked. Answer to all of this, you have that much pain, do an ultrasound. Find out what you have. Do you have one or do you have two?
We can say that one of the first signs that any parent or any young girl can take into account for suspecting about an anomaly is they have sexual or secondary sexual development.
Yes.
Breast, hair in
Yes.
the genital area, and even you have that development, your menses doesn't come. 2 years after, that's the first sign.
That's the first sign to start paying attention.
If you have secondary sexual development,
Yes.
breasts and hair, 2 years after, no menses, you have to go for a checkup to discard that you are not having an anomaly, right?
Yes, why? Why don't you have your period yet?
Yeah.
And maybe you're a bit delayed. Just get wait 6 months, but eventually you must know why. So if a pediatrician or a specialized gynecologist looks at the young girl and you do an ultrasound, you will have an answer. Is everything normal anatomically or not? And you might find that she has something different. Then you can intervene and help her early before it becomes a problem.
I have a lot of parents that comes to me and ask me, I have a girl, when is the first time I need to take her with you to do a checkup? Now, I think I have another extra information with what you're saying, that probably is the best is the earliest possible, just to check up, or is there some point that you say from this age you have to have a checkup, your first checkup? When would that be?
So the way to look at this is a young girl has a menses. Let's pretend at age 12.
Yeah.
It comes every month. She only bleeds for 3-4 days. It's not very painful. The mother has educated her. Everything is fine. No real reason to rush to see anybody. But if she says, I'm having pain, my bleeding is too much, my bleeding is too often, every 14 days, 21 days, it doesn't come at all, doesn't come for 3 months. Any of these things that are different from the usual is a reason to go see a gynecologist. Now, if you think about it, many of these things will maybe get better on their own. But how do you know unless you first see an expert to find out? In general, a menstrual cycle is like having a blood pressure or a heart rate. Every month a woman has it. If you don't have it, have too much,
Something's
too long,
happening.
too short, don't have it at all, the question should be why? And the parent can bring the child. The other thing to remind the parents and the child, a teenager, is you don't have to do an exam. There's no internal exam for a child. You're talking to them, getting the history, and then you can get an ultrasound. You can get laboratory tests, and you can figure out, is there a problem? So the first visit is not a visit that requires an exam. You may have to look at the development, but again, this is a matter of being gentle and allowing the young woman to become comfortable. You may say, I may need to do an exam because we have to see if you're developing correctly. Maybe, but you don't jump to that. First, you want to know the story. And there are many ways you can find the answer with ultrasound and labs, and you don't even have to examine the young woman. Right? But if you don't do it, and there is a problem, and she has polymenorrhea, menorrhagia, dysmenorrhea, painful periods, all these different things, or polycystic ovarian syndrome, which can lead to diabetes. Now you've missed the opportunity for years to help that young woman.
And the early treatment is the better.
Early treatment is always better. Early diagnosis, early treatment.
For example, when we talk about genital anomalies or genitourinary anomalies, probably there are some very complex and severe cases that are not that quite difficult to detect. Probably we don't know what to do or how to diagnose, but are too obvious. For example, if you have only one kidney or if you have no vagina, there's some signs that are very complex cases. I don't want to say easy to diagnose, but more obvious. Let's say more obvious. But there are some anomalies that probably are not that obvious, because you know that prenatal care now, the ultrasounds are very developed for pregnant women. So most of the anomalies are detected even from before the birth. But what are those anomalies, or what have you seen in your clinical practice that are the most common anomalies that probably most of gynecologists or even parents missed?
So the most common, which is sadly missed, which is easy, is no menses and you have an imperforate hymen. That means you just have a wall of tissue at the opening of the body. It's actually very easy for gynecologists to treat. You open that up, there's nothing wrong inside the body. It's from a different development system embryologically. You're finished. You solved the problem.
We can say very simple.
You solve the problem right away. Then there are more complex things where there's a block inside the vagina, a wall, a transverse septum, or a portion hasn't developed correctly, or you have, as the case of a double uterus, one blocked, one not blocked. Very hard to figure out because a woman is bleeding every month. You don't know why she's having more and more pain. It's because the other uterus is blocked. Again, if you're not certain, my answer always is you have a problem, at least do a good ultrasound. Find out if you have one or two. Does it look different from everything else? That gives you a chance, whether you're a pediatrician, a gynecologist, to refer to an expert. In my mind, it would be either pediatric adolescent gynecologist or a urogynecologist, somebody who has some background to be able to go further. Because all obstructions of menstrual flow lead to endometriosis. They have to be fixed surgically. There is no choice. If you don't do something, it will get worse. So it doesn't matter where the block is inside the body. Menstrual blood must come out every month. If it cannot, even part of it cannot come out, you have a very serious problem down the line. So answer is early diagnosis and detection again, and treatment, and correct referral.
And for example, when you have a pediatric patient or adolescent patient with this type of symptoms, the evaluations with ultrasound can be very effective, but sometimes could be very difficult. For example, if the patient is overweight and the ultrasound is not quite good, probably we can go to MRI. But when the point comes when we need to perform a vaginal ultrasound in these patients that have had no sexual life yet, and how do we deal, or how do we explain to parents and to the patient itself? And how do you perform this type of evaluations in pediatric or adolescents?
So very important for women not to feel that they have been forced, any age, right? So if you have done your best with ultrasound and MRI and you are still not certain, the answer is you put the person to sleep in the operating room, because then there is no concern about pain for the patient. Yeah. They don't remember, they don't move, they don't feel any pain, and you can do your job. At that time, you can do many things. You can do an exam, anesthesia, and check everything. And this does not damage the young woman at all. There's no danger for gynecologists to examine a young woman in the operating room. It's very safe. You do that, you could decide at the same time to get permission to look inside the body, do what's called a diagnostic hysteroscopy. You're looking inside the uterus. You can do a diagnostic cystoscopy, look inside the bladder. You can do a diagnostic laparoscopy, look inside the abdomen. Again, it requires a specialized person either who does urogynecology or minimally invasive surgery or both, or it's a team. It really doesn't matter. You are putting the young woman to sleep to get the correct answer if it is appropriate. But that, I think, is a judgment by the doctor. You first do the basics, you do the labs, you do the imaging, you do as much as you can, and then there is no other choice. You can't really do a transvaginal ultrasound on a 13-year-old. And anyway, you don't get good information. So you've actually done, you have no rapport with the patient, you haven't achieved anything. So my absolute rule is I don't do anything without asking permission. So I'll ask the young woman, can I do this? If they say no, my answer is fine. No, we'll find another way.
Okay. And for example, here in Latin America, I don't know if in the US is the same, but the concept of virginity here is really huge, or at least is some hard topic to talk with parents of the patient and even with the patient. Sometimes where we need to do procedures of somehow internally, vaginally, and they feel that we are altering that state of virginity. And sometimes I like to explain that virginity is more like a spiritual, moral concept than a biological one. But how do you handle this concept? Have you found this type of parents that are asking you, but my girl will lose her virginity?
So this is a common concern by parents and societies across the whole world, not just here or US, Asia, everywhere. The opening of a woman's vagina, the introitus, has a hymen. And there are many types of hymen. Think about it. All women, unless they have a block, will have blood come out. There is a canal through which the blood comes. If a gynecologist, using the right equipment, which is very small, is able to look inside, nobody can tell anybody was there. There's no damage done. There's no change in anatomy. It's just the person. So it's not as if there's a wall that's broken. There's no such thing. If that's the case, every woman will have a block and every woman would have endometriosis in the whole world. So that's not true, right? The hymen doesn't get torn. Hymen is a hymen. It can be circular, circumferential, annular. Different types. They're all normal, just different people. Just like black hair, brown hair, blue eyes, whatever. So this concept for parents, I often show them a diagram of the different types of hymen and say, these are all normal variations. All of them allow blood to come out of the vagina from menses, and they're all normal. And your child is one of these things, and it's okay. And if you do an exam, be very careful. We use small instruments, obviously. You can do all the work to check and figure out what's wrong for the child, and you haven't changed anything at all. So there's no issue of losing virginity because you haven't done anything other than do a normal exam without altering anatomy at all.
Well, and this is complex to explain to some parents, but it's a topic that probably we have to explain it like a necessity in the necessity of make a good diagnosis for this girl, for this patient. And I know that you are a referral physician in the US. Probably the very complex cases in pediatrics or in adolescents are going to you from all over the US. And what are the most complex cases that you have in this group of patients?
There are patients who come with multiple anomalies to have, and they do need surgery. there are patients who have a portion of vagina missing and need a reconnection between the uterus and the vagina. Those are very difficult.
It's complex.
So there's a variety of rarer cases of patients who are normal human beings, normal woman, has ovaries, develops breasts, but internally the gynecologic portion is different and sometimes needs intervention, especially if there's obstruction, or sometimes in order to allow the young woman to have a normal activity in terms of sex when she has marriage or a husband or a partner. So it depends also on the age and what's required. So sometimes we defer the surgery because it's not required for 10 years, and then you come back. Sometimes it's immediate because it should be done right away for the patient's safety. Very much a matter of each person is unique. You figure out what's the problem and how you can solve it and how to prevent long-term problems for the patient.
You mentioned in one of your speeches or your talks that there's some type of anomalies when you have to prove or show not only the parents, probably the patient, if he or she is XX or XY. We are talking here about genetics of gender or sex, because there's such a deep or complex anomaly that actually we don't know what they are, at least genotypically speaking. Mm-hmm. Which cases are those that when you go into the karyotype to try to answer if his or hers, what is your sex? And for example, this is a very hard topic because when you have these anomalies, probably they have race, like a girl to a person that is XY or otherwise. Mm-hmm. What are the cases that get us into this point where we need to do a karyotype to show what is your sex?
So, for example, you have somebody who comes to you at, say, 15 or 16, mm-hmm. has developed breasts, has some hair, but no menses.
Yeah.
And you do an ultrasound and you find there's no uterus. There's no cervix. You can't find anything. Mm. Well, either they have what's called Mullerian aplasia or Rokitansky-Kuster-Hauser syndrome, just means the Mullerian system, the female system, did not form at all. Or they have something called androgen insensitivity, which can be complete or partial, and that is a person who is genotypically, that means the chromosomes of that person are 46XY male, mm-hmm. but has grown up as a woman, mm-hmm. and phenotypically looks like is a woman. And for those patients, the gonads are really testes, they're not ovaries. And they're usually not found in the pelvis. Sometimes they can be higher up in the body.
Like trap testes.
They just don't come down, they don't descend. So if they're there, the testosterone, the hormone from them, is converted to estrogen by an enzyme called aromatase. Well, they can develop breasts, but eventually there's a higher risk for cancer in those gonads, and they have to be removed. The real challenge for say the patient with androgen insensitivity who has developed in this way, or somebody who is 46XX female but has no uterus, the challenge for both is mental, is to come to terms with who you are. I remind the patients that they are human. Mm-hmm. And for both of them, they are female. One is grown-up female, the other is genotypically and phenotypically female. The other is genotypically male, but grew up as a female and believes they are female. Mm-hmm. They can go on to lead normal lives as human beings. They're just different. And you have to provide a lot of support, including referral to psychiatry, a therapist, whatever that person needs to have them understand that they have a common humanity. They're just different. It's all right. The only sad thing is if you're born without a uterus, you cannot have your own child. You can't give birth. But I have patients who have had what's called surrogate. They've taken the eggs, mixed it with the sperm. Somebody else has carried the baby, and they have children. I have several patients like that. So it's not impossible, of course, much harder. But it's important to stress to both types of situations that they are female and they are normal.
Yeah, because I may think that, for example, I'm a father now, And you are always aware of what your children are okay, are developing well. And if someone tells you there's an anomaly that probably is not that quite complex, but a simple anomaly, you will get really stressed out.
Correct.
And I cannot imagine the impact to a girl or a boy 15 years old, and you tell them, sorry, you are chromosomically
Different.
You were raised as a girl, but you are an XY, a male.
Yes.
The impact of that is I don't know if devastating is well said, but at least it's a huge impact. And how do you handle this case? Did you send it to psychiatry, psychology?
I do, but you also provide support yourself, right?
Yeah.
I mean, these patients see me fairly frequently, but you're also trying to work with them as they mature. So parents often come and say, well, my daughter is born without a uterus, fix it. Because when you're born without the uterus, bullary aplasia, you often have a very small vagina. So sexual activity would not happen in the future. So you have to do something about that. But you also have to look at maturity of the child. If the child or teenager is 15, 14, they're not ready to do dilation. They're not ready to embark on anything. You have to address the expectation of the parent and the patient, the child, the teenager, together until they are at the point where they're ready to be able to do something with you. And so you often have this sort of statement like, just fix it. There's not a quick fix. It's a process. And you have to support that person through it as they go through it. And everyone is different.
Yeah. And I think we have talked about high impact topics here with these anomalies. So many of those who are looking at this or hearing at this podcast can get scared, you know.
These are rare. All of this is rare.
That's what I want to we talk a little bit. How frequent or how prevalent are these type of anomalies, just to not increase the desperation of the fathers who probably are hearing to us.
Some of these are 1 in 70,000, 1 in 30,000, 1 in 10,000. These are rare things.
Yeah.
They're not common. Endometriosis is more common. We don't know the percentage in the world, but I don't know. I don't like guessing, but it's not like just 1% or 2%. I think it's a lot more.
Yeah.
We just don't know the real number, but it's enough that it's a serious issue.
Okay, so this is probably because of the underdiagnosed.
Yes,
because we are not diagnosing properly on time.
Yes.
The endometriosis. So I think this has been an amazing podcast. Dr. Mama, thank you for accepting. I will love you to give a final message to the ones hearing us. Probably there are some parents worried about they are matching what we mentioned, the symptoms we mentioned with what their girls are having, so they may be worried. But they may be hearing this podcast and a physician that has a patient like this. I want to end this episode by you telling a message to parents and probably to physicians who are treating this type of patients that they don't know what to do or they are not certain about the diagnosis.
So probably the most important thing I've learned is to listen for both the patient and for the parents and the doctors to listen to the complaint. And then take a moment to think about it and see who should then help you get to the next step. So if the parent is concerned, let's say they bring the young woman to the pediatrician. The pediatrician also must listen, not just say it's normal for you and go home. Dig a little bit. If you're not sure, refer to a gynecologist. Refer to a gynecologist who has expertise in children. Go down the path until you are certain that the complaint of that person has been addressed. And if you did that, you would automatically have to do a history. You may have to do some of an exam or no exam. You would have to do some imaging. You'd have to do some labs. You would come to a conclusion, what's really going on. Now you can do some treatment, whether it's pain pills, hormonal therapy, whatever it may be. But you wouldn't go down this path unless you are curious and you're paying attention to what a person is saying. So I think it applies to both parents and doctors at all levels, is to listen carefully and not assume that they're just making it up or exaggerating.
Okay, that's a beautiful final message. start listening. Parents, doctors, physicians that are attending their patients. It's good to listen.
Yeah.
So, Dr. Mama, really thank you for having this moment with me here. And this will reach hopefully many, many people. And hopefully someone who is getting through this process will hear and will say, okay, I'm not alone. So that's one of the purposes of this podcast. So thank you so much for accepting being here with me.
Thank you for having me. I appreciate it.
Y con esto terminamos este podcast, Women's Hub, con el Dr. Abner Santos. Muchas gracias por la sintonía y tenemos más temas para ustedes. Manténganse al pendiente.